Good day, everybody, and I really want to thank you for joining us. My name is Jim Blumenstock, and I am so privileged to serve as the Senior Vice President of Pandemic Response and Recovery for the Association of State and Territorial Health Officials. And I'm also very pleased to serve as the moderator for today's session and our conversation that will take place in a few moments. ASTHO really felt that this would be a good time to reconnect with you all as we continue to work to protect the public health from COVID. And since we're about halfway through the National Month of Action, to take this opportunity to discuss the steps states are taking to meet President Biden's aim to vaccinate 70% of the adult population with at least one shot by July 4th. I think you all know and hope you would all agree with me that we continue to make significant progress in this effort. New cases, hospitalizations, and percent test positivity rates are down, and majority of the school districts are now offering full in-person learning. So clearly those indicators in themselves suggest that progress is being made. Additionally, over 300, or I guess just shy of 311 million COVID-19 vaccine doses have been administered in the United States since we began this campaign the week of December 14th, with 64% of adults 18 years and older receiving at least one dose, and 54% now fully vaccinated. Also of note, 87% of adults 65 years and older have received at least one dose, and 76% are fully vaccinated. We are also very pleased to report that just within the last 24 hours, the District of Columbia and New York State became the 15th and 16th jurisdictions to individually achieve the target of 70% of adults 18 years and older with at least one dose of vaccine in their arms. And there are a number of other states that are sort of, right at that point in the high 60s that I would say any day now would fall into that category. We do have the pandemic clearly on the run, but not yet fully fading in our rearview mirror. We must continue to do more and to basically protect the health of the public. So today, our panel members will now briefly discuss their efforts, accomplishments, and some of the barriers that they are encountering and trying to overcome to improve vaccine access, confidence, and uptake, and how their response posture will shape up in the months ahead, during these summer months. So now, please allow me to introduce to you our panel. As always, we have a stellar assembly of a few of ASTHO's members to be with us this afternoon. First, you will hear from Dr. Nirav Shah, who is the ASTHO president and the director of the Maine Center for Disease Control and Prevention. Dr. Shah will be followed by Elke Shaw-Tulloch, who is the administrator of the Division of Public Health in Idaho, in the Department of Idaho Department of Health and Welfare, and also an ASTHO board member. And then our last panelist will be Dr. Lee Norman, who is the secretary of the Kansas Department of Health and Environment, who is also one of our newly appointed board members. So each of our panelists will spend three or 4 minutes to sort of give you brief prepared remarks on their state progress and efforts, and that will give us really ample opportunity for your questions and conversation. So with that, Dr. Shah, let me turn the program over to you.
Great. Thank you so much, Jim, and good afternoon, everyone. As Jim mentioned, my name is Nirav Shah. I am the ASTHO president, as well as the director of the state of Maine's Center for Disease Control and Prevention, our public health agency here in the state of Maine. And I'm delighted to be able to chat with everyone today about where things stand with COVID, vaccination efforts, and what we are seeing on the horizon. I think the bottom line for me today is that states are not slowing down. Even though metaphorically and in some sense practically, July 4th as well as the post-July 4th period represents for many folks, something of a close to the pandemic. At the state level, we're not slowing down. I think I speak for many of my colleagues across the country when I say that many of us feel that we've made good contact with the ball, but we still need to round the bases now. Indeed, states across the country are starting to plan for fall activities, such as back-to-school immunizations, to make sure that all kids have caught up fully with their immunizations, not just COVID, but other essential childhood and adolescent immunizations. States are also thinking about how to vaccinate younger children, say those under the age of 12, if or when the US FDA grants an emergency use authorization for that group. States are planning to be ready for when that happens. And then finally, starting to think about the possibility, if required, if recommended rather, for repeat doses and revaccination in the fall, if indicated. Notwithstanding all of that, challenges remain. Even though we just passed 600,000 deaths yesterday as a country, overall, I remain sanguine. In my own state of Maine, cases are down, hospitalization rates are down 60% in just 2 weeks. And with that, thankfully, deaths have continued to fall as well. Indeed, across the country, the openings or reopenings that we are seeing are in large part because of vaccination. But again, challenges remain, and all of this comes at a time that we are contending things like the Delta variant, which brings with it higher transmissibility and perhaps more severe illness. That makes vaccination more important than ever and raises the possibility, the Delta variant, of focal outbreaks in states with lower vaccination rates, as well as the possibility of enduring outbreaks into the fall. That being said, there have been some positive changes. The recent shelf life extension for the Johnson & Johnson vaccine provides more breathing room around the management of doses that would have otherwise started expiring at the end of this month. It also opens up the possibility of using those doses not just within our states, but potentially internationally as well. This all comes at a time when vaccination rates have started to slow down. One important note there is that slowdowns in vaccination rates are not unexpected and have occurred in previous large-scale vaccination efforts. Some of that is structural. The latter half of any enterprise just happens more slowly than the first half, whether you're vaccinating a country, building a highway, or building a skyscraper. The last half, the last mile, the last quarter mile is always requires more effort. States are doing many different things to try to understand how to get to that last mile, that last quarter mile. In my own state here in Maine, one of the things that we're doing is convening focus groups among individuals who have not been vaccinated to try to understand 5 key things. Who are these individuals? Where are they? What message would convince them to get the shot? What messenger would be best suited to deliver that message? And then finally, in what setting would they feel it'd be most appropriate to get the shot? We're hoping to have data in the next few weeks that will inform our next phase of activity. Much of that next phase of vaccination activity will focus and involve bringing vaccines directly to people. Whereas the first part of our activity, we ask folks to come to the vaccine. The next phase will ensure that we are bringing the vaccine to those who are hesitant. So with that, I'd like to turn things over to my colleague, Elke Shaw-Tulloch from the state of Idaho.
All right. Thank you very much, Nirav. I appreciate it. In Idaho, we continue to see a decline in cases, much like the rest of the nation, and hospitalizations due to COVID in all age groups. Our percent positivity is dropping. We're currently at 3.9%. Our vaccination trends are mirroring those that we see on the national level for the most part, but we are seeing a consistent drop in the state. We're currently at just under 50% vaccinated for all age groups in Idaho, but our age 65 and older group has already met the president's goal of 70% by July 4th, which is very encouraging. But we clearly have areas of the state that need special attention to get us closer to that overall goal. Many of the comments that Dr. Shah mentioned, we have the exact same experience here in Idaho. We are in the state. We've been surveying Idahoans throughout the course of the pandemic to better understand their beliefs around the vaccine. And according to our recent survey data, we know that many people continue to be concerned about vaccine safety, and and that they are taking that wait and see approach. They want to see what's happening with the vaccines, and then slowly we're seeing them make some decisions about whether or not they will take the vaccine. We also know from our survey experiences that we need to make vaccines extremely convenient to accommodate people's very busy lives. So because of all this, we're employing a wide variety of tactics to increase our confidence in the vaccine, increase access to the vaccine, as well as motivate people to get it. To increase our confidence in the state, we have quite a few things that we're doing. We're training pediatricians and other health carers about the vaccines to increase their knowledge, as well as their ability to talk to their patients through motivational interviewing. We're providing toolkits for pastors and other religious leaders to help with those conversations. We're collaborating with trusted leaders and partners to communicate or carry out messages about vaccines. We're providing biweekly press briefings to review information about vaccines, and as well as educational messaging about vaccine safety. Increased access, we've offered provider capacity grants throughout the entire time we've been giving vaccines in the state to help monetarily support providers' participation in vaccine administration. We have many grants that we're offering for mobile vaccine clinics. We're offering these clinics statewide through a variety of partnerships, as well as providing a mapping tool for these providers to advertise their clinics. We've partnered with pharmacies and providers to increase demand by extended hours and walk-in clinics, as well as offering a wide range of types of clinics, from shots to homebound individuals to mass vax clinics to on-site clinics for businesses like our dairy industry and manufacturing, to community organizations and pop-ups and walk-in clinics. And so we've seen the same things across the nation as states are investing in opportunities to get vaccines to people. We're even going into rodeos and fairs and concerts and offering vaccines. And then we're also, of course, trying to work with special population groups like our Medicaid population and developing mailings for the youth and their guardians to encourage vaccines. To motivate individuals, we're also offering local efforts that run quite a spectrum, from shots, that include shots for shots, groceries, grocery discounts, paid time off, points towards wellness programs, gift certificates, pool passes, nights at a resort. Businesses are becoming very creative, and along the lines even of covering shifts to get vaccines and discounts on insurance. And supporting all that, we are working on our communications efforts, using the information that we're getting from these surveys to really shape what our media looks like. And we've been using messages that are shared by real Idahoans, including doctors, teachers, and first responders, about the safety and effectiveness of the vaccine, reminders that the vaccine is free and easy to access, and also correcting this information. So we're using a variety of media channels, social media, and so forth. And then lastly, for the summer, we've been really focusing many of our efforts, like I mentioned, on the activities that occur here in Idaho during the summer, making vaccine available where people are, and the incentives that match those opportunities. And then we'll be amplifying a campaign we have running right now called Take Back Summer, that really is encouraging youth vaccinations while we're working on our back to school messaging efforts and ensuring that youth start their vaccinations during the summer to be ready for that fall startup. We're encouraging a whole family approach and encouraging all family members to get vaccinated. And lastly, I'd like to mention we do have one exciting partnership that we have ongoing or occurring this summer with one of our Idaho tribes, our local public health departments, and our Canadian officials to conduct a vaccination event for tribal members on the Idaho-Canadian border on June 21st, which is Canada's Indigenous Peoples Day. And we're looking forward to that event. In summary, Idahoans are very proud of their rugged independence and in making decisions based upon their own value systems. Our approach is really to try to meet people where they are and help them feel confident in their decisions about taking the vaccine, as well as make it convenient and accessible, even if that means that it might take a little bit more time to reach our goal and meet the nation's goal. We're optimistic that we can continue to see vaccines be administered in Idaho as these vaccines become more normalized and as Idahoans become more comfortable. With that, I'd like to turn it over to Dr. Norman.
Thank you, Elke, and thank you for the invitation to be here today. In addition to my role in the state government as a state health officer and secretary, I'm also a colonel in the U.S. Army and currently in the Kansas Army National Guard as a state surgeon. So some of the things that we see on the civilian side, I also see on the military as well. You're going to hear some common themes here. One is that in terms of vaccination rate in Kansas, I think we're doing pretty well, but to be honest with you, I think we'll struggle to get to the 70% mark by July 4th. We're in the 60s now, but there has been a slowing down in the vaccination rate. We'll see. We have moved largely away from the large mass vaccination venues. As Elke pointed out, we've kind of maximized those, and we're now having to be content with much smaller numbers of vaccinations at particularly given events. The mass vaccination clinics were very successful at getting shots into people's arms. But now we're having to reach out by different remaining populations that tend to be less vaccinated, smaller groups often defined by race and ethnicity, geographic locations, sometimes religious affiliations, age groups, to name a few. As such, it requires a lot of customization and a lot of effort. To Nirav's point, the big gains came early, and now it's in the baseball vernacular, small ball. Sites, we were very successful. Schools are out here now for the summertime, but we were very successful in the 12 and olders in vaccinating, and we look forward to when kids come back in the fall to accelerating that activity in schools. Work locations and businesses have been great. We do a lot of meat packing and meat processing in the state of Kansas. A third of all beef in the United States, for example, comes through Kansas. The people who work in those settings are less likely to be vaccinated, and that's been a very efficient place to vaccinate persons. Vaccine confidence and hesitancy has been a problem. Elke made mention of this. We're very typical of a southern state that tends to have a higher incidence of vaccine hesitancy. Some of those folks in that group will never get vaccinated, I'm convinced. So we've not written them off, but we've done everything we can to make it appealing, make it easy for everybody. And that, again, meeting them where they are, as Elke pointed out, churches, professional groups, minority community groups, et cetera. We do have a similar approach in terms of incentives, tying vaccine to fun and established community events, whether it's with strong local partners. Local partners are critical to establishing credibility of this vaccine. Novel events, we did a NASCAR Speedway event a couple of weeks ago, which was successful. As pointed out, we also pay medical offices an administration fee for giving the vaccine. We want them to have every opportunity to give vaccine and to make it worth their while to do so. Media, we do have broad-based and some customized media campaigns, and we have the concept of what we call the, quote, movable middle, quote, people who are saying, I'm kind of riding the fence, but I'm kind of leaning toward it. We're trying to give them, through culturally appropriate, multilingual, frequently asked question documents, fact-based media, information, every opportunity to get the vaccine. We've had a lot of success. We put together what we call our Social Vulnerability Index Explorer, and that looks, whether it's by a racial group, ethnic group, socioeconomic group, can drill down to a census tracker zip code that basically says where have we been successful and where have we been less successful in getting vaccine to people. And I'm proud to say that in the state of Kansas, when you look at Hispanic Latino populations versus non-Hispanic Latino populations, the Hispanic Latino populations have a higher percent of vaccinations than the non-Hispanic Latino populations. I think that's really great and shows that effort is working. Convenience, well, pushing for extended hours at pharmacies and other vaccinating sites to make it so when people work nights or graveyard shifts can have it almost any time, or people who work day can get it at night. Staffing for the fall. One of the things we worry about is, do we have enough people? I think we're going to see an accelerated need in the fall for a variety of reasons, and we want to make sure. We've had a lot of turnover in local health departments. That's true nationwide. That's been true here in the state of Kansas. So we're looking a lot at medical manpower and public health manpower. The federal relief monies have been great. We pushed it to local health departments for them to staff up, but we have to make sure that we can assure that the pipeline of trained staff are there. We are moving away. We know the National Guard troops will not be able to stay stood up for forever, and we're relying more on state and contract nursing to do the vaccinating and less on National Guard troops. We've been doing a lot to bolster school nursing programs because school nurses are critical in schools, but may not have enough to do a rigorous vaccination program. And in anticipation of children returning to school, we need to staff up our school nursing, and especially when it comes to having emergency use authorization for the vaccines in those kids less than 12. That population makes up about 15% of the state of Kansas. So that would be a big influx. We do not anticipate a need for increased hospital staffing because we've had no shortage of hospital beds and staff at this point. The vaccine plans after the July 4th, I pretty much described that above. We will rely on the growth in the vaccination efforts, especially in a few segments. Primary care physician practices. We're enrolling more primary care practices all the time. and schools is another one. And then even down to the individual businesses, we're finding that those are excellent local partners to work with. And then finally, surge in cases. Nirav mentioned this about the strain that's emerging as problematic. We, I think, could very well see a surge in cases. Ideally, it's a race between the vaccines going into people and the current or future variants. I don't think that we're going to see a real influx into hospitals, but the variants of concern are all that as they enter the picture. We've really geared up our whole genomic sequencing so that we know what we're dealing with. We do a lot of surveillance in wastewater, both to find out how much COVID-19 is out there and what's the genetic makeup, what are the strains. We're even piloting the use of air testing to do the same thing. Last comment, with return to K through 12 education and higher ed, there'll be a combined push, most certainly, for enhanced testing and vaccination of those groups. And that should prevent the surges that could otherwise occur, and also identify them early for case investigation, contact tracing, and the traditional management of those outbreaks. So there's reasons for optimism and reasons for caution. With that, Jim, I'll turn it back to you.
Dr. Norman, thank you so much. And great presentations by all three panelists. And I think while we've been treated to surely a sense of their strategies, tactics, and activities, their efforts certainly are representative of everything that's going on across the country. I think they've highlighted the efforts that are underway regarding making access more convenient, building confidence, and really motivating the public, as Dr. Norman had mentioned, the movable middle. And I think we've heard all three states of how they are approaching that. I think the one last point my takeaway was that, when we wake up on the morning of July 5th, that is still business as usual. There will be more work to be done, and we will continue to work to drive in all of these activities to continue to increase the level of vaccination uptake and to do our very best to suppress and contain disease transmission in the communities. So with that, Travis, if I could ask you to give our guests instructions on how to put their questions in queue, and let's begin.
Yes, sir. If you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. Again, press *1 to ask a question. Pause just for a moment to allow everyone an opportunity to signal. Our first question comes from Dan Goldberg, Politico.
Hi, thanks for doing this. There was a real effort about a month or so ago to push vaccines to primary care clinics, pediatricians, et cetera. Can you talk about how that effort is going? There were concerns about the size of the pallets from Pfizer and Moderna and doctors struggling with that. And also, if I may, can you talk about the barriers that still exist? Is it mostly hesitancy and you need to inform people, or are there still things like childcare and inability to get to a vaccine site that are hampering efforts?
I'm happy to start. This is Nirav from Maine. On the primary care piece, we've been pleased with the rollout to date, and we're going to be ramping it up into July even further. We're going to take it up a couple notches as our large-scale vaccination sites start coming offline. That will the doctor's office will be an even more important venue. There have been two changes that have helped encourage uptake from a structural perspective. The first is recent changes to the handling and storage of specifically the Pfizer vaccine. Dan, as you're aware, it need not be in the ultra cold environment for the same time period as originally thought, thanks to stability studies. That's allowed specifically pediatric and family practice offices to start using the vaccine. The other thing on the size, you are absolutely correct. We at ASTHO have been urging, recommending, nudging our federal colleagues as much as we can to move not to larger pallet sizes, but smaller tray sizes. The move from 1170 to 450 was welcome, but we've heard consistently from members as well as doctors on the ground that going from 450 to 10 is really where we need to be. What we've done at the state level is break up the pallets so that if a provider doesn't feel that they can use 450 doses ever, we at our central warehouse will break up a pallet so that they only need 30 or 50 doses, and that's what we'll send them. But make no mistake, we still strongly urge the federal government, specifically the FDA, to work with manufacturers to move towards smaller preparations of all three vaccines. Ideally, single-use syringes. Short of that, something even smaller in multi-dose vials. Your second point then was about existing barriers. There are two categories of individuals. Having largely vaccinated the early adopters, there are actually three categories of individuals, I think. The first category now are those who have not been vaccinated because convenience is a barrier, convenience or access. The second category are those who have earnest questions about the vaccine. This is what Elke referred to, I think, as the wait and see group. And then the third are those who are just not going to get vaccinated. Right now, we actually are starting to get some survey data that suggests that for many of the folks in that first group, convenience factors still matter. So we're still offering free rides to people. Anywhere they need to go to get a vaccine shot, we'll get them a ride there, for example. And we're still seeing good uptake with that. Over.
Great. Nirav, thank you so much. Elke or Lee, anything more to add?
I might just add one more thing. This is Lee, and that is that when Nirav talked about surveys, and we survey to find out who do people trust, who do they want to hear from, and it again focuses on this primary care as a locus of vaccinations, and because people want to hear it from their doctor, their medical providers, people that they know and trust, and these are all tied together, smaller doses, more easily pushed out. Here in the state of Kansas, much like Nirav talked about, we'll break apart a whole shipment and ship out one vial even at a time. And so that puts a lot of logistical nuances and barriers, but we try to meet that need. Over.
Yes, thank you.
And thank you. This is Elke. I really don't have anything to add. Exactly the same experiences here, doing the same practice of breaking doses up into smaller shipments, working with our providers so they have that their own personal confidence in having those conversations with patients. And I think I covered everything else in my opening remarks, so I don't really have anything else to add.
Good. Thank you. And the only thing to mention that is just one classic example of the role of public health in and handling the upstream aspect of this medical countermeasure to make the provider sites more convenient and more accessible and less challenging for them in the field. So thank you. Travis, next question.
Next question, name and company was not recorded.
Hi, this is Michelle Smith from AP. I'm just wondering, do you think that there needs to be, with the slowing rate of vaccinations, you talked about some of the changes that you're making. I mean, does there need to be more of a change? Are you kind of finding that some of the things that you've been offering, like lotteries, aren't getting the results that you hoped? And also, in some cases, we're seeing a rise in some places, we're seeing a rise in cases. Do you foresee a spike with the Delta variant growing around the country? Are you concerned especially in those communities and the counties where there's higher rates of non-vaccinated?
I'll start at least on the former question, and then invite my colleagues to weigh in on everything else. On everything. As to the former, Michelle, I think it's states have had mixed success with various incentive programs, and as we are thinking about in our own state where to go, we're probably going to be deploying something similar to other states with the sweepstakes, in the very near future. And my view on that is that if at a minimum, if it helps turn the direction of the declining rate, that's the best of all scenarios. But at a minimum, if it just doesn't cause that rate to go down even further, then that's a win too. So, when you compare the amount of money relative to the benefit of getting just a couple percentage points of more folks vaccinated, to me, it's a really good investment. As for the latter question on the Delta variant, I think the answer is yes, that's a risk in less vaccinated areas, but I'll let my colleagues Elke and Lee weigh in on that.
Great. Elke, we'll go to you first.
Yeah, I'm happy to go next. To start out, I'll say, yes, of course, we're concerned. We continually watch everything that's happening in our state. In Idaho, we're concerned about variants. We're concerned about the slow vaccination uptake in the state. I mean, we have a range from 26% vaccination rates in some counties, clear up to 82% in others. And so we know that while I mentioned Idaho's rugged individualism, that definitely is reflective in what we're seeing in some of the geography in our state, and some very independent and want to make their own decisions about things. So we're constantly weighing all of that. That's why we're doing a lot of our survey work to better understand people's attitudes and beliefs around the vaccine. We've experienced some feedback that some of the larger incentive programs, like a lottery or something that has a heavy monetary incentive, is almost looked at with skepticism as well. So we're currently weighing, whether or not we want to do anything like a lottery to motivate people to get the vaccine. And what we're finding, as I mentioned, is that really the confidence and time to learn more about the vaccine is really what's going to resonate here and be important for us. So I think, like Dr. Norman said, I think we're going to be hard-pressed to reach the president's goal of 70% by July 4th, but we have pockets where we've already exceeded that or met that in certain age populations. So the bottom line is we're I think, slowly trying to roll out and, like I said, meet people where they are, help them understand, get their questions answered. And as we've been watching, our vaccination rates are just kind of slowly eking up over time. And I think that's what it's going to need to take for us here. Dr. Norman?
Thank you. And Lee, anything?
Yeah, just one thing. I'm agreeing with my colleagues again. One thing I might add is that we still hear a lot from people who are reluctant at this point to say, well, it's experimental. And I don't, and granted, a lot of that kind of use of that phrase comes from kind of, I think, misinformation, particularly through the social media. But I think there's something to this about FDA approval. And I think there are a certain number of people that are riding the fence saying, EUA means nothing to me. It's still experimental. When the FDA approves it, that's when I'll get it. Now, time will tell if they come through at that point, or if there'll be some other kind of excuse or reason given. But I think that FDA approval, when it comes to that, will help our cause in terms of getting people vaccinated.
Thank you all. Travis, next question.
Our next question comes from Cheryl, last name and company not recorded.
Hi, it's Cheryl Stolberg from the. Hi, it's Cheryl Stolberg from the New York Times. Thanks for doing this call. I'm wondering if you could talk a little bit about the necessity for booster doses. What is your current thinking about whether and when booster doses will be needed, and where will those doses come from?
Sure. Dr. Shah, can we turn to you, because I know you alluded to that in your prepared remarks.
Yep. Thank you, Cheryl. I'll start on the scientific piece, which is based on briefings that I've received or that we've received as a group at ASTHO from our colleagues at the US CDC and other venues. My understanding is that right now the current thinking is that it may be just a bit too early to tell with finality whether second doses, boosters, et cetera. I lump all of that under the broad category of revaccination. Whether any of that will be needed in the fall. Certainly, the better job we do now lowers the likelihood that, per Michelle's earlier question, variants could run loose and precipitate the need for revaccination. So there is a direct link between what we do now and what we may need to do later. I think ultimately it will be the CDC and FDA and other federal officials and scientists who make the ultimate call on the necessity or the indications for revaccination. What I want to underscore is that states are ready. And of course, this is taxing. State health departments have been running multiple marathons over the past 16 months. But if what is needed will be a remobilization effort around revaccination, that is what your state health department will do. Now, revaccination may occur on a different cadence than did the initial phase of vaccination starting in December of last year. It may be, for example, braided with seasonal flu vaccines and such things, so it may not have the same degree of urgency for everybody. But there are likely to be subpopulations among those who are vaccinated, those who live in nursing homes, for example, for whom revaccination will have a higher priority. That's what, at least in our state, that's what we're planning for right now if it becomes needed. I don't have a clear view as to when that final determination may be made.
Thank
Dr.
you.
Shaw, thanks so much. Right. Next question, Travis.
Our next question comes from Andrew Ball, Topeka Capital Journal.
Hi there. This is going to be a little more Kansas specific, perhaps, so I appreciate the indulgence. For Dr. Norman, in Kansas yesterday, we had our emergency declaration and you talked about personnel challenges.
Andrew Bach.
Is your agency and our local health departments ready to pick up the slack now that, for instance, the Kansas National Guard is not going to be able to support vaccine efforts? You know, is there any concern in the months ahead that this will put more of a crunch on capacity?
Yeah, that's a great question, Andrew. It's nice to hear you on this venue. For those on the call, yes, the Kansas legislature chose to not allow extension of the emergency declaration. So at midnight this morning, the emergency declaration goes away, which by statute causes certain things to peel off. The National Guard, for example, winding down of the State Emergency Operations Center, puts more of a onus of the responsibility on my own agency. I think we're well positioned to do that. Andrew, we've been blessed, as you know, with federal funding all along, coming in through the various relief funds from the feds that we've pushed on out to the local. We have 105 counties and 100 local health departments. They have the ability to staff up. We've also done some of the similar fundings with school districts so that they can staff up in their school nursing programs. There are some logistical concerns. You know, a health agency typically doesn't run warehouses and doesn't tend to have trucks and truck drivers and those kind of things that are required for distribution. So it is a logistical matter, but I think we're in good stead. We met for 2 hours this morning on exactly this topic. And short of acceleration in the number of cases, I think we are in a good stead to do this. So I think we'll make it through this fine. It does cause more pressure on our agency, though.
Thank you for the question, and thank you, Dr. Norman, for that answer. Travis, next question, please.
Our next question comes from Tian Huang, NPR.
Hi, thanks for taking my question. I have kind of a Kansas-specific question. Dr. Norman, I was intrigued by what you said about piloting airborne surveillance for variants. I was wondering if you could talk a little bit more about that.
You cut out for just a minute, but I think the question was about air surveillance. Yes, we're okay. Great. We're piloting this, and this is not a new technology. You'll remember back when Senator Daschle had an envelope with white powder and the concern that there could be things in the air that needed to be measured. We were using that same technology and saying in certain enclosed spaces, would it make sense to sample the air and then do PCR testing on that filter paper to see if anybody in that room is exhaling the virus? And I think it's a little too soon to know where that fits in. We are hypothesizing that would be for things like small enclosed classrooms, perhaps certain work settings where people work in tight quarters. Probably less so for like busy hospital emergency departments where you've got people coming and going all the time, lots of people coming in, housekeeping staff, meal service and the like, coming and going. So the jury is still out on that, but we think it will likely have a place. I think of it rather like when we do pooled samples of people to find out if anybody in a cohort of, say, 20 people has it, then going back and testing those people that one or more of them had the virus. But time will tell to see if it is something that's practicable.
Great. Excellent. Again, a great example of using innovative approaches using existing technologies. So, Dr. Norman, thank you for sharing. Next question, please.
Our next question comes from Isaac Stanley Becker, Washington Post.
Hi, thanks very much. These calls are always great. I wonder if some of you mentioned the mixed success of some of the financial incentives. Could you speak to what the most successful strategies have been, specific programs, specific initiatives that have either addressed access issues or hesitancy issues? And then secondly, the topic of misinformation also came up, and could you speak to the challenges of addressing that and the sense at this point of how much misinformation and confusion about issues of safety and so on is driving safety concerns? I think we all saw some of the recent comments at legislative hearings about magnets or forks, or I forget what the specific conspiracy theories were, but how dominant is this and how much of a challenge is that for you as health officials?
Thank you. So let's open it up. First question on any good indicator of how effective initiatives are for motivating people to get vaccinated.
Yeah, I can start on. Oh, Elke, please go ahead, Elke.
Thanks. Yeah, I'd be happy to start with some of the things that we're finding. And as I mentioned, in Idaho, we've been hearing recently that some of our financial motivators have not necessarily been the most effective. For example, some businesses have offered monetary incentives for their employees to get vaccinated and didn't see a huge uptake of that. But when we have made vaccinations more available where people are and worked on the access piece, then we've seen a higher uptake because it's part of a person's daily flow. We kind of talk about the comments we've heard where if a vaccine were to fall out of the sky and hit me in the arm, I'll get it, but I'm not going to interrupt my busy daily life to make that effort and go in and get a vaccination. So that's why we're really focusing on, walk-in clinics, pop-up clinics where, wherever they turn, there's a place that's easily available for getting the vaccine. So that seems to be making a difference. As well as, some community leaders that are really sort of rallying the troops, if you will, to encourage community members to get out there and get the vaccine. And then, of course, with some of the misinformation pieces, we've seen, the Latinx population here in Idaho, there were definitely some concerns around infertility. So we're working with community leaders in the Hispanic population to make sure that they were kind of doing that myth-busting approach. We're really using, again, those trusted community leaders to help address some of those. Like you said, there are conspiracy theories that seem to pop up at every corner. So every time we hear of anything, we're making sure that we have social media pushes and everything that really focus on correcting some of that misinformation. And
thank you.
I'll add just very briefly on top of what Elke noted. The first iteration of incentives that we did here in Maine was focused on incentives that mirrored Maine's ethos of getting outside and enjoying the outdoors here. And so our incentives were aligned there. There were 6 that we offered, and overwhelmingly the crowd favorite was an LL Bean gift card, which is, for those who have been to Maine, you can see why that one worked. And we did an analysis to compare vaccination rates in the period before the incentives versus the period immediately thereafter. And we did see an uptick, particularly in more rural areas. Indeed, many of the incentives were targeted for folks in rural areas, such as a free fishing license, things of that sort. So, we can discuss the magnitude of the impact, but directionally, we did see a change, and I was encouraged by that. As I mentioned a moment ago, we are now probably in about an hour and 13 minutes or so, our governor will be announcing our next round of incentives. The other thing I want to just note really quickly is, although there has been a focus on the financial incentives, we've also tried to highlight the non-financial incentives of being vaccinated, particularly for younger folks. So for example, the promise of getting kids back in school, being able to play sports again, going out to eat, those things also seem to have resonated. And then finally, on the educational point, Isaac, what we've been careful to do is to distinguish those who are uninformed from those who are misinformed. And we've tried to do videos and communications partly to distinguish those. There are some folks who have earnest questions and they simply don't know the answers. There are others who believe they have an answer, but it's not one that's supported by science. As I think you can probably hypothesize, that latter group, those who are misinformed, that's a bit more of a challenge from a communication standpoint. Fundamentally, and Dr. Norman mentioned this a moment ago, the one communicator, the one messenger that seems to be able to help those who are misinformed is someone's doctor.
Let me add one more thing, if I may, Jim. And it's really, to answer your question, Isaac, is a little bit about an approach. And what we found here in Kansas, and I mentioned it earlier, mass vaccination clinics were easy. And the reason was because people self-selected, they were anxious, chomping at the bit to get the vaccine, and they showed up. Now this having it smaller, more customized, and spread out through 105 counties is a challenge. One of the things that we did, and I will say tumbled to, we have what's called the Kansas Leadership Center. It's an organization that takes community leaders from every community, large, medium, small, frontier, rural communities, and trains people on government, finance, leadership, all sorts of things. Well, what I knew we needed was ground troops to go out and work with their respective communities. So we enlisted and gave a pretty significant grant to the Kansas Leadership Center to host community meetings throughout every county in the state of Kansas, so that they knew the people that were coming to Nirav's point, misinformation versus just a hunger for information. They were hearing this from people they know and trust, business leaders, church leaders, and the like. So ground troops was really important to work at the local level, been very effective.
Thank you all. Travis, next question.
There are no further questions in the queue at this time.
Great. Well, we'll give you all one more moment. And should a question come in queue, Travis will let us know. But let me certainly take this opportunity to at least share with you some of the closing remarks. First, we want to thank, our members, Dr. Shah and Dr. Norman, for being with us, as well as Administrative Shaw-Tulloch. I think all three of our members, as I said before, clearly gave you a great snapshot of their leadership and what their agencies are doing, but certainly it is representative of what's happening across the country for the issue of increasing vaccination confidence, access, and uptake. These efforts will continue, and I think in the days and weeks to come, we will continue to see progress and success in this effort. I certainly do want to thank the members of the media and press for being with us today as well. Your questions were spot on, certainly reflective of your understanding of the issue, and you extracted some great information from our panelists that really augmented their prepared remarks to really show you, how it's sometimes technically challenging and how even societal implications and influences sort of change the course of action that jurisdictions need to follow to be successful in their mission. So, Travis, I'll give you one more moment to see if there's any more questions, and if not, we will adjourn the call for today.
We did have a couple of people queue up.
Okay.
No name, no company.
Hi, it's Michelle Smith from AP again. Just one quick question, which is, of the people who aren't, the non-vaccinated yet, do you have any sense of the breakdown of Dr. Shah had mentioned, there's 3 categories, with one group being they're not going to get vaccinated, and then the people who want to be, who it needs to be convenient for them. I mean, do you have a sense of the breakdown among those groups of the percentages of who's left?
Michelle, this is Nirav. I don't. One of the reasons we're doing that market research that I mentioned earlier, convening focus groups, surveys, things of that nature, is to better characterize that group. I think I have a qualitative sense per the categories that I mentioned, but really getting granular, sizing that group, understanding where they are. That's kind of one of our projects for the next 2 weeks or so.
Great. Thank you.
I might comment on this. We have a little bit of a glimmer. We know that African Americans in the state of Kansas are as a racial group, are less likely to be immunized, and I think some of it is due to historical distrust in vaccines and therapies, and some of it I think is still barriers based on, as the things I mentioned earlier, census tracts or that kind of just logistical questions. But the group that I think is the largest group that we're having struggles with is 25 to 45-year-olds, and they're certainly the ones that are getting sick with COVID-19 and going in the hospital because they don't tend to be as highly immunized as people that are in older age groups with underlying health conditions. So the 25 to 45-year-olds are the ones that we're really going after to see if we can improve that.
Yeah, and this is Elke, and I can add, based upon the surveys that we've done, is that we've typically been running around. I sort of look at it as the people who will never get vaccinated, and then you have, of course, your opportunity group, and then those folks who will get vaccinated. But we've been, in general, running around 20% of our survey respondents saying that they will definitely not ever, no way, no how, get the vaccination. It varies every time we do a survey, depending upon how we're recruiting survey participants. But very similarly, those that will not get vaccinated tend to be male, 18 to 34-year-olds, conservatives, and so that's, we want to spend our efforts really focusing on that opportunity group, which we have much better opportunity to change behavior and get the vaccination in.
Michelle, just to round this out real quick, one of the things that we've started doing as a marketing note is to publish around once per week, or at least publicize around once per week, the percentage of people in Maine who are in the hospital because of COVID who are unvaccinated. And we've started collecting that data from hospitals, and it varies, it's around 80+% of people in any given week who are in the hospital because of COVID who are not vaccinated. Now, that number has to be interpreted with some caution because the number of folks who are hospitalized has plummeted, but still, that's the hope, to Elke and Lee's point, for folks who just don't quite believe that the risk of COVID outweighs the risk of the vaccine. That may be a number that is motivating.
Yeah, that is for sure. Thank you all. And Travis, we have time for one more question if there is one.
Yes, sir. Name was not recorded.
Hi, thank you for taking my question. I just wanted to ask a little bit more about vaccinations in states' Medicaid population. I'm wondering how much of a discrepancy in uptake you've seen in your Medicaid populations versus the general populations, and curious to hear more about what you're doing to improve that, if anything. Thank you.
Great. Let's open it up to our panelists.
I might comment. This is Dr. Lee Norman. We do have the Medicaid program in my agency, so we do keep a good eye on it. A couple of things and it's a managed Medicaid state. We have 3 managed care organizations who manage our Medicaid program, and our uptake has been and you can look at it by age group or race or ethnic group, et cetera, or geography also, and it is at or a little bit higher than the non-Medicaid population, and we feel that it's probably due to the fact that it's more of a managed practices. And then secondly, the administration fee, we fund the Medicaid program to pay to clinicians is about twice of what the rate is for other populations. So there's incentives for the practices to reach out and immunize. They would have done that anyway philosophically, I think, but the fact that there's a little bump in their reimbursement makes it possible. So I think we're doing pretty well from that perspective in our Medicaid program.
Thank you, Dr. Mohan. Nirav or Elke, anything else to add before we adjourn?
Nothing else for me. Thank you all for your time today.
Great.
Yeah, same here. Thank you.
Great. Well, again, allow me to thank you all very much. This draws to a closing our time together. ASTHO will continue to host these bedside briefings with our folks from the media as we approach critical milestones or opportunities in our campaign to bring an end to the pandemic that we are currently facing. So thanks, everybody. For the media, should you have additional questions or requests, please feel free to reach out to Jane Esworthy, who is our Senior Director of Public Relations, and her email address or the Dropbox would be media@astho.org. So again, thank you all very much. Please enjoy the rest of the week. Be safe, and please feel free to disconnect at this point in time. Bye.